Hi, welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Maureen Macbeth. She's a physical therapist and certified lymphedema specialist. Today's Kevin MD article is Beyond BMI, Why Weight Management Must Look Inside the Body. Maureen, welcome to the show.
Kevin, thank you for having me. This is something I'm really passionate about talking about.
All right, so your article is Beyond BMI, Why Weight Management Must Look Inside the Body. What led you to write this article and then talk about the article itself for those who didn't get a chance to read it?
Sure, Kevin. So it was really personal for me. Last year, I unfortunately had to have a big surgery. I had pre-melanoma. Actually, it's melanoma in situ. For those of you who don't know, it's like early stage melanoma, but it's a really deadly disease. And it was right on my nose. I had to have a paramedian forehead flap. So the makeup kind of covers it. And I had a good plastic surgeon, but I had major facial reconstruction surgery. And with that, I could do nothing for about 3 months. And I gained a lot of weight, admittedly, a postmenopausal woman. So this is tough. Like, I'm a physical therapist. I should know how to take care of my body and how to lose weight. And I was struggling. So I finally, talked to my doctor and went on a GLP-1, but it wasn't without a lot of consideration because I've been in the PT space for over 30 years and I've been using bioimpedance spectroscopy, which is what I work with a company that uses that as a technology for lymphedema and for body comp. And I was scared because of the results I saw people I had tested and their body comp, really their metabolic engine had been destroyed.
So what does that mean when you're seeing these people on GLP-1s, they lose a significant amount of weight. When you see their body composition has been destroyed, what does that look like from your standpoint as a physical therapist?
Yeah, so as a physical therapist, right, my equipment that I've been studying, I had a research device in 2007 for this bioimpedance spectroscopy, so a very accurate way of measuring fluid in the body, and we can get tissue outputs. So I started looking at this years ago and noticed women going through breast cancer who had normal BMIs but had really elevated body fats. So move fast forward 2017, I had this fancy stand-on device and again started testing every one of my patients on it. So over that time, GLP-1s became more prevalent, and I had people coming in saying, "Oh yeah, like they wouldn't actually tell me first. That's part of the problem. The stigma of being on a GLP-1, people didn't want to tell you. But
Hmm.
I would see these body comp results, and I'm like, huh, you've lost 50 pounds, but your scale weight is looking great. But I put you on body composition testing, and you have really low skeletal muscle mass, you have exceptionally high body fat, and it's not making sense. So I started going back and looking at more and more patients, and this was a trend that we saw. Then got involved professionally with some of the organizations looking at body composition across all areas of patients in medicine and did the research and said, we know that people on these GLP-1s, they're losing muscle mass, they're losing weight way too fast, and then all that's left is kind of like a depleted body.
Mm.
So, so my concern going on one was I sort of had a bias, as clinicians, right? We all have
Yeah,
we
yeah.
develop these cognitive biases because we've seen too many things. And my doctor was kind of pressuring me. She's like, "Why don't you want to go on a GLP-1?" I'm like, "Because I'm scared to." And, I've seen too many people lose their metabolic engine, I like to call it, their muscle. That's already happening as we age, as we know it. So I wanted to really make sure. So I actually put it to the test and sort of did a case study N of one on myself. And my goal was to make sure, and this is what I talk about in the article, is that we as medical practitioners and as a entire group that really has an opportunity to make sure that this whole GLP-1 thing goes in the right direction is we've got to really push to make sure that patients are getting tested for their body composition before they start these drugs, that they're monitored throughout, and that we don't let them lose weight too fast or not exercise or not eat the
Mm.
right way. Because with drugs, what do people want? They want a magic easy button.
Yeah. So from the perspective of a physical therapist, people going on GLP-1 agonists, they lose a lot of absolute weight, but it sounds like the weight that they're losing is primarily in the form of muscle. Now, from that perspective of a physical therapist, why is that so dangerous, losing so much disproportionate muscle mass?
So it's really dangerous because we know that it's that muscle that is really driving our health. And so a lot of the data, again, I'm biased towards the cancer space, but we have had so much literature showing how important exercise is for people going through cancer. And so if they aren't moving, if they aren't exercising, if the exercise isn't being dosed, they're not going to actually preserve their muscle. And so preserving muscle really sort of takes two inputs, right? It takes dietary inputs and we have to use our muscles. I mean, disuse atrophy used to be a really big problem in PT because there were so many conditions that we just said, no, you've got to rest. Well, that's not true anymore. If people are going through cancer treatment or even thinking about like orthopedic injuries, we get people moving now. And as a physical therapist, it's my job to make sure I dose exercise correctly. I mean, we can't let people lift 2 pound weights. That doesn't do the trick. And so while total physical activity is super beneficial to people, we actually need to make sure we're lifting the right amount of weights and then that people have the proper dietary input. And so I also consulted a dietitian for my journey. And that was really important because a lot of people don't realize when they go on these drugs, you're not really interested in eating. I mean, you still enjoy eating. Trust me, I
Hmm.
still love a really good meal, but you don't have that drive like you did before.
Yeah.
And that's some of that gut brain axis thing that is changing. But the problem with that is if you're not getting the proper nutrition, and they have study after study showing people go into caloric deficit that's too great to maintain. So they're going below what their body needs on that daily basis. So, for example, my dietitian set my goal was 1,500 calories a day, and I would still lose steady, slow weight, but my bottom was 1,200.
Yeah.
And I really struggled because I tracked and trended this. I actually have this book that I ended up using a paper journal. It was more helpful than an app. And it really made me just put down to make sure I was getting those protein macros and the calories each day. But I found after 2 weeks, I had already dropped like from close to 1,500 down to like 1,238. And that
Mm,
got me thinking, I'm like, gosh, if people aren't really tracking and trending this, they're not going to know.
sure.
And so about 3 to 5 months in, I had an instance where I had decreased the amount of time I was getting on the bioimpedance device that I have. And I started to pick up a little fat mass again, and my skeletal muscle mass started to dip.
Hmm.
And it took me about a month to correct that. And it was, again, the biggest problem is the diet and people not being able to do that. So that's where the article, and I've really tried to use my own personal situation to get the conversation going.
So many people just step on a scale or use body mass index to track how much weight they've lost from GLP-1. Are you recommending that they also check their body fat index, their muscle mass percentage, along with
Yes.
absolute weight?
Absolutely. And actually, it's not just me saying that, but all the organizations that are trying to set guidelines for this are all now recommending that you use some other form of body composition testing, that BMI is not adequate and the scale could actually be dangerous almost. So again, a lot of the weight that people lose in the beginning is actually water weight.
Hmm.
So it's sort of amazing to be able to track that. And so the technology again, so I'm a senior medical affairs liaison. So I'm like the nerd behind what my company does. So I get to read all the research and everything.
Yeah,
And a lot of people don't realize that in the beginning, a lot of early weight loss is fluid loss.
sure.
And so you need to track that too. You've got to make sure you're taking enough fluid in, and then you've got to really get everything fine-tuned. So I always think about kind of like three things is that, the patient has to understand their body fluctuates too, and fluid fluctuates. And so this is also why the scale people really get freaked out. They get on the scale in the morning, they get on at night, they're like, oh my gosh, I gained 2 pounds. And they're like, I've got to do something. So they stop eating the next day.
Yeah.
And that's the worst thing they could do. Or they stop drinking that extra glass of water. So that's where the tracking becomes really critically important. I don't even think we really know the optimal time frames of like, should we be tracking once a week, every other week, once a month? And I think that's what the research right now is really trying to figure out in this space.
So, in terms of the listeners on GLP-1s listening to you now and want to track some of the body fat index and muscle mass, how can he do that? Can he just go on Amazon? I know they sell all these things on Amazon. Is that good enough? What would you recommend?
So that's good for tracking and trending. Like a home device can be good, but I really feel like it's incumbent upon the medical profession. If we're prescribing these very powerful weight loss medications, we should be matching it with tests, right? We don't prescribe a drug and then not do blood work, for example, or any type of, we've got to match our treatment with our ability to actually understand critically what's happening with the patient. And, again, that's why I've looked for opportunities like with you to really get the word out to people that, you saw the Super Bowl and you saw all the ads for GLP-1s. And you probably heard already, I think a certain company got an FDA letter this week. And that's big news because there's a huge amount of money behind
Mhm.
this. There's a lot riding on it. There's a lot of issues with our entire public health about this. And so as a medical community, we've got to take that responsibility. And that's why I've been trying to go public and saying, I know how scared I was as a healthcare provider to even go on this medication. This has transformed my life. I don't know where I'd be without this. I mean, I've lost 26 pounds since last June, and I've been able to preserve my muscle mass because I've been tracking and trending that. It's really exciting, but it's also just had other downstream benefits that, this podcast isn't long enough to talk about those.
Sure.
But I think this is medication we should be using, but we've got to be really wise about it. And again, I'm just I know I'm preaching to the choir here, but we've got to get the rest of our colleagues to recognize how important if we're going to use this, reduce the stigma, track and trend these patients, make sure we're using the proper objective measurements. And that also includes as a PT, like strength and functional outcome measurements as well.
So tell us, for those on GLP-1s, exactly what kind of exercise they should be doing, how much should they be lifting to preserve that muscle mass during their weight loss journey?
That's a tough question to answer because it is quite personalized. We're starting to recognize the exercise prescription. There's something called like a one rep max. So if you don't know how to figure that out, like you need to see a professional. So whether that's like an exercise physiologist or professional trainer or a physical therapist, if you're very exercise naive, you should probably be asking your doctor for a prescription to go, let's say, to a PT who can help with this, or, an exercise physiologist, because they have to see where you're at right now. The good thing is we have a lot of age-related norms, things like grip strength, and there's some other easy tests that even doctors can learn to do in their own office, like sit to stand test. And you
Mhm.
can really find out if someone is, below where they should be for their age. And if they are, that's someone who really needs professional counseling versus someone who could likely go to the local gym and hire a trainer. But slow and steady wins the race. Again, the first week you start, you can't start off hard. There's a lot of adaptive benefits just from starting to get into regular exercise. But we do know the sports medicine, they've got recommendations for the average person that they can start to do. And it's really 2 to 3 times a week. These exercise sessions need to, be enough to stress your body. So probably the word I want everyone to look up is myokines. If you don't know what myokines are, it will be one of these moments where you're like, wow. But these are all the signaling things that actually come from our muscles. And these are
Mhm.
what drive all the wonderful adaptive and protective benefits of exercise. And we've got to be able to stimulate those enough. I hope that
Now,
answered that question.
now, what about those patients who are listening to you and saying, "Oh my gosh, I've already lost so much weight, but my body fat composition is higher than it should be." Is there any way to reverse the cascade of muscle loss once it begins during a GLP-1 journey?
That's another great question because they're trying to figure that out. So I think a lot of people, there's never a bad time to start exercising. So if you are on a GLP-1 and you're not doing any extra physical activity, then you need to talk to your doctor about that, whoever's prescribing it, and say, I need to know more about this. And it's never too late to start. We've done exercise studies in people in their 80s and 90s, and they can reverse some of these changes. So you may not have, be able to grow big giant muscles, but you really can do something at any point. So it's never too late to start. The key is, trying to recognize that this is you can't just let the drug do the work. Because if you just let the drug try to do the work, you're going to run into these problems.
Now, how about to those other physicians who are listening to this, and I prescribe my fair share of GLP-1s, in addition to exercise during that journey, is there anything else that we need to counsel patients that we may not know about that you have experience with? What are some other things patients should know about?
I think that the side effects and monitoring those can be important. There are a lot of common side effects. People will talk about that feeling of fullness or dyspepsia, like indigestion. And I think they just have to make sure I would love to see better tracking methods that people can just honestly say to you, like, hey, here's what I'm experiencing this week. I actually used a book, modified a book that a colleague had made, a dietitian had made for other conditions. And it
Mhm.
was really nice because it had an opportunity to say, how am I feeling that day? How's my function? Am I still able to do all the things I want to do? Am I having any other disruptions with sleep or something else? Because again, I think for me, it's made me like more perceptive about my own issues and a better communicator back to my physician. And I think that's what we're trying to do is develop that communication so that I remember reading something that you wrote about like we shouldn't be gatekeepers anymore,
Mhm.
but we really should be, we want to be that active partner
Yeah.
and help our patients find, the best path forward. And that's really what I feel like, again, I'm trying to do is open up that conversation. And I'll just say, I knew no one on a GLP-1. None of my colleagues, no one would admit to me they were on a GLP-1 till I came forward with it
Mhm.
publicly. And now all of a sudden, I know probably 30 people that are on GLP-1s. And make sure your doctor knows if you're getting this on the side, don't do it that way. Make sure the conversation's with your physician. It's really important. And then again, what physicians can do is make sure the patient has an opportunity to track and trend their body comp, make sure they have opportunity to get to exercise. If they need a dietitian, they need the professionals.
Mhm. We're talking to Maureen Macbeth, physical therapist and certified lymphedema specialist. Today's Kevin MD article is Beyond BMI, Why Weight Management Must Look Inside the Body. Maureen, let's end with take-home messages that you want to leave with the Kevin MD audience.
So take home message, GLP-1s are a phenomenal tool. We should be embracing them, but we should be embracing them with the guide rails that we need for safety, for efficacy, and to make sure that patients' lives really can be transformed with them.
Maureen, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thanks again.